Well, hi everybody. Welcome to this month's iCubed. This is episode number 19, believe it or not. Oh my gosh, this is my labor of love. And I'm happy that you're joining us this month. Now, before we go on, for all of you who are attending the ACEP Scientific Assembly in San Diego this year, 2018, Emergency Medicine News is actually going to be doing an event. It's going to be me recording iCubed live. I'll be recording an episode of iCubed at the EMN booth, so please come by and see us in action. Speaking of coming by, please don't hesitate to come up to me if you see me at ACEP or any other conferences. I promise I don't bite. Just stop me if you see me and just say hi, because I would love to meet you guys. Okay. Well, let's just dive into this month's case, and I have a dear friend and colleague back. She's already done 2 episodes with us, 2 fabulous cases, and here's another fabulous case. Would you introduce yourself?
Yes, hello. Thanks, Alice. I'm Elizabeth Ottney. I'm really excited about being here today to see Alice's videos in particular. For those of you who don't know what this is about, prepare yourself. This will be interesting.
Exactly. Well, I assume all of us ER doctors really have a strong stomach, so this shouldn't be a problem. But even for me, it's a little bit, dicey. But the patient is a 79-year-old male, and he comes to the emergency department. He has a history of metastatic squamous cell carcinoma of his left mandible. He has diabetes. He has a history of stroke. He came in for evaluation because there's maggots in a wound in his neck.
Yes, I was there that night. And Alice grabbed that case before I had a chance, and I was not terribly disappointed.
Yeah, the light bulb went off. Oh, another episode for my screencast. Mm-hmm. All right, so anyway, the patient had had a left hemimandibulectomy, or the left half of his mandible resected in July of 2017 due to the squamous cell carcinoma. He actually was taken off chemo just a couple weeks before he presented to us, and he was put on hospice due to metastatic disease. He was accompanied by his wife, and she said that, the wound opened up that day or the day before, actually, and then they noticed the maggots today, or the day upon presentation, and the patient complained of some pain in the wound. Are you ready?
I'm ready.
So here's the video. It's a pretty big wound. How long has it been this large?
It just started.
Like how?
We were just talking
how
about.
long
He
ago?
used to have just the lumps, and the wound just started maybe a day ago.
Oh.
Yeah, it just. To tell you, I just noticed that the hole in there today.
Okay.
That's something else. I have to say, though, the wound clearly looks pretty clean.
I know, amazingly so.
Which is what you can, sometimes expect with maggots present. But minus the maggots, that wound isn't that frightening otherwise.
Right. So actually, I took this video after I had already reached my finger in there and kind of pushed aside some of the larvae. And so the initial look at this was even much more disgusting and gross than this, because it was just a pool of larvae in the bottom of the wound. Okay. But anyway, I was able to get verbal permission from the patient and wife to go ahead and film the wound. And so what test do you think I do next?
You tell me, Alice.
Of course I'm going to scan the guy. What are you talking about? Of course I'm going to scan the guy. I was hoping that we would see like maggots on the CAT scan. So I love scans. If you're a regular viewer of this screencast, you know that I love to look at scans and order scans and show scans. So with a CAT scan, there's different views, of course, but different planes. But this is the coronal plane. You can see the nose, and you can see as we scan down, this wound is so deep, right? It goes in on the right side, just to the right of midline, and just is a cavern going in towards the left. So we can see where the hole in the front is that we see on the video, but then you don't see what else is behind there. So when I was looking at this patient, I'm thinking to myself, how close are these maggots to the carotids, to big red? Yeah, so it's quite remarkable what you see on the scan.
But you don't see any maggots.
No. Okay, so I get the scan back, and I honestly had really no real idea what to do with this patient's wound. So I put out a call to consult ENT. In the meantime, I take a Yankar and I start suctioning these babies out of there, and I thought I had cleared out what was in there. But
probably not, looking at the size of the wound on the CAT scan.
That's right. So they're on that left side. So I go back sometime later after they had, we had put gauze over the wound, and the wound, the bottom of the wound is filled with maggots that had just, I'm sure came out from the left side of the cavernous wound, right? So
I wouldn't have even thought of suctioning or even try it, because I'm like, there's no way I'm getting everything out of there, plus the wound needs to be debrided and specialty care. I probably just would have left it.
Yeah, I didn't know what to do. I felt compelled to do something, I suppose. When you get confronted with this sort of obvious medical problem, if you will. So that's what happened in terms of the wound and the maggots. I did get a call back from ENT. We kind of talked about it, and essentially it was, well, there's not much to do in the ER. You just need to make sure he's well otherwise, and send him back to his ENT in the morning, which made sense, and the family and the patient was fine with that. I did give him some pain medicine to take at home if he needed it, and some antibiotics. It was because there was some cellulitis. So, short and sweet for the case presentation. What do you think we're going to learn the first learning focus is?
Well, you didn't use POCUS here, so that's not learning focus number one.
That's right. Well, let me tell you this. You're going to learn much more about maggots than you ever wanted to know or imagined that you would want to know. So first learning focus is emergency department treatment of myasis. Myasis is the medical term for infestation of live vertebrates, humans or animals, with dipterous larvae. Now, dipterous meaning it's an order of insects that have two wings. Wound myasis, which is what my patient had, is infestation of a wound with dipterous larvae, right? Self-explanatory. All reliable e-medicine website gives me some information, guidance, myasis treatment and management in the ER. Now, apparently there are hidden larvae in the skin that you have to try to remove, or some people want to try to remove. So if you have a patient that has a larvae peeking out, there's a few different methods. They recommend applying petroleum jelly or liquid paraffin, which is wax, or beeswax or heavy oil, or even bacon strips over the punctum, right? And it's supposed to coax them and entice the larvae to come out. They said, don't use nail polish because it suffocates the poor thing, right? And then at which point you can't get it out because it won't crawl out, right? Once they've crawled out or nearly crawled out, you use tweezers or forceps to capture them. And anecdotally, they are said to emerge in 3 to 24 hours. I think in the United States, it's not likely to happen a whole lot. I imagine other countries, third world countries, there may be more of a problem, and they may get under the skin like this picture shows. Another approach would be surgical removal with local anesthesia. You can anesthetize the skin lesion with lidocaine, and then open it up, remove the larva, and then you close it, the wound that you created. care must be taken to remove every part of this larva, because you will incite a foreign body reaction if you don't. That's because their bodies are covered with spines, and these spines hook them to the soft tissue. Malignant wound myasis, which is what we have. Malignant wound, right? This is a guy with a metastatic disease. So malignant wounds are well recognized as a predisposing factor for wound myasis. Wound myasis is more commonly related to these open skin type of malignancies, such as basal cell carcinoma and squamous cell carcinoma. My guy had the squamous cell carcinoma of his mandible. The presence of unpleasant odorous secretions might be a clue to the presence of maggots.
Was this an odorous wound?
Yes, quite, yeah. L. sericata is the most common fly larva found in these malignant wounds. It's a green bottle blowfly. Fun fact, right? Anyway, so in terms of emergency department care, that article, article recommended 2 ways. One was to remove irrigation, and the other way was to apply chloroform in light vegetable oil or ether to the maggots, and then remove them probably by forceps or tweezers. They didn't talk about Yankar, suctioning them out. Yeah. Learning focus number 2. Did you know that there is such a thing as maggot debridement therapy?
Yes.
You did?
I'm aware of that.
Uh-huh.
Just like there is leech therapy.
That's
so
right.
I'm aware of it, but I assumed that it was, restricted to certain universities, just like hyperbaric treatment, things like this. It's going to be with the specialists that determine the appropriate wound for it and know what they're doing. We're never in our lifetime going to prescribe maggots.
Right. So doing research on maggot treatment in the ER, of course, led me to this. This is fascinating stuff. So maggot debridement therapy actually sort of started based on this orthopedic surgeon that was based in Maryland, and he presented 2 cases in 1930, two wounded soldiers, and it's a fascinating read. So I'm going to read it to you because it's really, really fascinating how he came to this conclusion. It just kind of highlights how our experiences really help us with devising therapies. In his original article, he describes the situation, describes the presentation of these soldiers really well. At a certain battle during 1917, 2 soldiers with compound fractures of the femur and large flesh wounds of the abdomen and scrotum were brought to the hospital. These men had been wounded during an engagement and in such a part of the country hidden by brush that when the wounded of that battle was picked up, they were overlooked. For 7 days. 7 days they lay on the battlefield without water, without food, and exposed to the weather and all the insects which were about that region. On their arrival to the hospital, I found that they had no fever, no evidence of septicemia, no blood poisoning. Indeed, their condition was remarkably good. I could not understand how a man who had lain on the ground for 7 days with a compound fracture of the femur without food or water should be free of fever and of evidence of sepsis. On removing the clothing from the wounded part, much was my surprise to see the wound filled with thousands and thousands of maggots, apparently those of the blowfly. These maggots simply swarmed and filled the entire wounded area. The sight was very disgusting, and measures were taken hurriedly to wash out these abominable-looking creatures. Then the wounds were irrigated with normal salt solution, and the most remarkable picture was presented in the character of the wound which was exposed. Instead of having a wound filled with pus, as one would have expected, due to the degeneration of devitalized tissue and to the presence of the numerous types of bacteria, these wounds were filled with the most beautiful pink granulation tissue that one could imagine. There was practically no bare bone to be seen, and the internal structure of the wounded bone, as well as the surrounding parts, was entirely covered with the pink, rosy granulation tissue which filled the wound.
Similar, actually, to your neck wound. I mean, on the surface,
Yeah.
that actually looked like pink, rosy,
right.
Healthy, viable tissue.
Right, that was your
non-infected.
That was your comment when you saw that. Exactly. So this is a picture of the blowfly in larvae, Califoridae phoenicia, which is what Dr. Bear had described in those soldiers' wounds. Anyway, so MDT, which is maggot debridement therapy, had its ups and downs through the decades, but over the past probably a couple of decades, it's become established treatment. I don't really know how widespread it is across the country, but there's a lot of research actually, and a lot of reviews and articles about it. This one by Ronald Sherman, it's a very extensive and well-written review article titled Mechanism of Maggot-Induced Wound Healing. What do we know and where do we go from here? So MDT, there's 3 benefits of maggot debridement therapy. The first is debridement, obviously. Number 2 will be the antibacterial effect of MDT. And number 3 is that MDT actually has a growth stimulation effect. That is an electron microscopy of a larva. So the debridement is thought to occur because these little worms, these little maggots are covered with spines, plus they have these teeth, hooks, and they crawl through the wound. And as they're crawling, they kind of break up the necrotic wound tissue. And that is thought to be the debridement part of what they do, what the maggots do. And a fun fact is that because of that mechanical debridement, maggots have been certified by the FDA as a medical device.
Yes. And
not medical not a medicine, but a device. Isn't that funny? The antimicrobial effect of the maggots is thought to be from the fact that they secrete lots of enzymes that break down the necrotic tissue, and the enzymes also have antimicrobial compounds in them. The growth stimulation effect, again, due to the secretions the maggots have, which stimulate fibroblasts, endothelial cells, and increases angiogenesis. With modern technology and science and advancements of biochemistry and all that they were able to actually show these effects. In terms of medicinal maggots, in the US, the maggots are regulated by the FDA as a prescription-only medical device. Not medicine, but medical device. I think that is hilarious. In terms of preparing the medicinal maggots, flies are typically oviposited into porcine liver. The eggs are then separated and chemically sterilized. The resultant larvae are sterile upon emergence from the egg, and these larvae are maintained under aseptic conditions before they're applied to the wound. So it is definitely controlled and not just random. Well, so that's it. Quick and sweet.
Nice.
So, Elizabeth, have you seen maggots in your patients?
Yes.
Yeah?
Only in the lower extremities, though, and they were almost identical patients, 2 different patients, different times. Diabetics, with diabetic ulcers to the lower extremities, very wet, weeping wounds, and, of course, they were virtually immobile in their home.
Right.
Unattended, no friends, family, home health, nothing coming into the home until finally they called 911. So, to me, as soon as we identified it, nurses went in and kind of deconned the area and things like that, and then we got them to the care that they needed because those wounds, they had multiple other wounds as well. But it was not nearly as nauseating to me as that open neck wound. That's an element I haven't had.
Yeah, so I did have one other patient a few years ago. It was a young guy who was homeless, and that's very common, I guess. And he unwrapped this wound dressing, gauze dressing on his leg, and just literally probably 50 maggots fell off the surface of his leg, and there were more, right? So it was quite nauseating. So anyway, there's a lot of information actually out there. I just didn't know because I really never looked into it.
Well, neither did I. So when I knew that we were going to do this iCubed, I read a very little bit in an airport before I caught a flight. So I can't say that I fact-checked any of this information.
Elizabeth, you're not the only one, I'm sure.
So I did find it interesting, though, that there's evidence, historical evidence, that the Mayans and even the Aboriginals in Australia used maggot therapy for their wounds. Of course, this is pre-antibiotic, pre-modern medicine.
Sure.
Also, I guess Napoleon's army was known to have discovered maggot-infested wounds and found that these wounds were also quite clean under the circumstances. There's evidence also in the Civil War that the wounds were found maggot-infested and were doing quite well. So it's just interesting to me that it's actually, maggots have been around a very, very long time.
Yep.
Maggot-infested wounds have been around for a very, very long time.
And in modern science, what we've done is kind of organize it for it to be a medical therapy versus just randomly happening by nature,
Exactly.
So,
very interesting. So,
I think that's also interesting to know the history of it. That's why I read that original account of Dr. Bear, because it's just, I can just visualize him seeing these wounds and just thousands of maggots crawling out of the wounds going, oh my God! And then seeing that just to his surprise that the wound was clean, right?
Our initial instinct is to clean that wound, when in reality they're doing a far better job than we could do in those circumstances.
In those circumstances for sure. Right. All right. I promised my editor that in the history of the magazine they have never had an episode about maggots and wounds. All right. Well, thank you, Elizabeth, again.
You're very welcome. It was fun.
Yeah. Nauseating but fun.
Nauseating but fun.
So thanks everyone for watching this month. I hope that you learned something from this lesson about maggots in the wound. And not that I want you to see any in the but the next time you do, or if you do, you'll know what to do about them. And don't forget about ACEP. If you're going to be there, come say hi, and also come over to the EMN booth to see us record iCubed live. It will be on Tuesday, October 2nd at 11 a.m. at the break. And thanks for watching this month. We'll see you again soon.
Thanks, everyone.
Bye-bye.
Bye-bye.